Hello, I am Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. Next. Before we begin, I would like to share some meeting details. Closed captions are now enabled, and attendees can turn these on and off as desired. Interpreters can join the meeting via the phone number, ID, and passcode provided on this slide. A link to this PowerPoint presentation will be posted in the chat, so you can access the links on this slide. To receive continuing education credit, you must complete the session evaluation, including an attendance attestation. The link to the evaluation will be posted in the chat at the conclusion of the webinar. We will also send you an email with a link to the evaluation following the webinar. We will only be providing continuing education credit for live attendance. This webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. Due to the large number of attendees, the participants will remain in listen-only mode throughout the meeting. The presenters will be taking questions at the end of the session, so please feel free to type your questions into the Q&A box at any time. Next. This is the 15th Medicare webinar that the Medicare Mental Health Workforce Coalition has produced. Please find information for videos of the previous presentations via the link on this slide. Next. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieve this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program. The coalition members are listed on this slide. Next. Today's webinar is titled The Year in Review and What's Ahead, Counselors and MFTs in Medicare. First up, we want to welcome back Dr. Doug Jacobs, Chief Transformation Officer in the Center for Medicare at the Centers for Medicare and Medicaid Services. He is joining us once again and will review the first year of MFTs and MHCs in the Medicare program and what to expect in 2025. He will be followed by a practicing marriage and family therapist and a mental health counselor who will share their experiences as Medicare providers. Next, I would now like to introduce our speakers, and their full bios are in the slides for your convenience. Dr. Doug Jacobs is the Chief Transformation Officer in the Center for Medicare at the Centers for Medicare and Medicaid Services. In this role, he helps to lead center-wide efforts to move the healthcare system towards value-based care, advance health equity, and promote delivery system transformation. Prior to this role, he was the Chief Medical Officer and first Chief Innovation Officer for the Pennsylvania Department of Human Services, where he helped oversee the state's Medicaid program. Dr. Jacobs is a board-certified internal medicine physician, and he continues to see patients weekly while fulfilling his role as Chief Transformation Officer. Next. Carol Podgorski completed her doctoral degree in sociology and has master's degrees in public health and marriage and family therapy. She is a professor and associate chair of faculty affairs in the Department of Psychiatry at the University of Rochester School of Medicine and Dentistry. She is director of the Finger Lakes Center of Excellence for Alzheimer's Disease. She also serves on the advisory panel for outreach and education for the Centers for Medicare and Medicaid Services and on the New York State Coordinating Council for Alzheimer's Disease and related dementia. Next. Mary Jernigan has served in several levels of care, including art therapy groups, inpatient hospital, and intensive in-home and outpatient therapy as a community counselor. She is the immediate past president of the Licensed Clinical Counselors of North Carolina. Jernigan is a national certified counselor, a licensed clinical mental health counselor, certified clinical military counselor, certified mental health integrative medical practitioner, and an EMDR certified therapist. So we are in good hands today with all of these very qualified people, and I would now like to welcome Dr. Jacobs to begin his presentation.
Thank you so much, Jolie. It's really a pleasure to be here with you all today. And there's a lot to talk about after a 1 year of implementation of um, enrollment of marriage and family therapists and mental health counselors into the Medicare program. And so I want to start with a sincere thank you to really all of you who are joining here today, and especially to those who have enrolled and to those who haven't enrolled yet. Hope that you'll think about joining after this webinar as well. Okay, let's get started. Next. Okay, so quick background before we dive in a little bit deeper. Um, Typically, Medicare has certain restrictions under statute in terms of who can actually bill Medicare. And so in order to expand or add provider types that can bill Medicare directly, Congress must pass legislation. And in the case of marriage and family therapists and mental health counselors, that happened in December of 2022. And so then following its passage and effective January 1st, 2024, marriage and family therapists and mental health counselors can enroll in Medicare and bill Medicare independently for their services, furnished for the diagnosis and treatment of mental illnesses. So this is a big step forward, and is really a key component of how we're expanding access to behavioral health and thinking about expanding access to behavioral health in Medicare. Next slide. Okay, so the behavioral health strategy, which this is a core component of, I'll go into a little bit more detail soon. But at a high level, it aims to support a person's emotional and mental health and well-being through their behavioral health care. So especially during the COVID-19 pandemic, there was an acute increase in so many different mental health and SUD diagnoses. And so we've collectively been thinking about what we can do to expand access. So the 2024 physician fee schedule, the physician fee schedule is a rule that comes out every year. And so the 2024 physician fee schedule in particular was really important in terms of access to behavioral health care. And I'll go over some of the components, but the one in particular to highlight is allowing the enrollment of marriage and family therapists and mental health counselors. And this also, when I say mental health counselors, just as a caveat or some additional information initially, it also includes education requirements that I'll go over. And so we've had a number of enrollees already. Next slide. Okay. So the behavioral health strategy, which I promised I'd go a little bit more in depth into, in addition to the mission, which I already mentioned, the vision is really that beneficiaries are going to have access to person-centered, timely, affordable care that enables optimal health and wellness. And it really encompasses substance use disorder prevention, treatment and recovery services, ensuring effective pain treatment and management, and also improving mental health care and services. And therapists and counselors can be a core component of each of these. And so as part of the enrollment numbers that we've seen, we're hoping to make steady progress here. Next slide. Oh, there it is, perfect. So going over current enrollment, these are the enrollment numbers. For marriage and family therapists, we have about 10,315 that have been enrolled, 3, leading to a total of more than 56,000 practitioners that are new to the Medicare program. Many of you are probably new to the Medicare program on this call, which is fantastic. And that is a number that we're very pleased with, and we know is going to make just a huge impact for the Medicare beneficiaries. And some of the later speakers are going to talk about caring for this population, especially, and how it can be rewarding, and also some of the unique needs to consider. We have about 15,000 applications in the pipeline that are currently that you might see the abbreviation MAC, MAC. That is the Medicare Administrative Contractors, and they help with the enrollment based on geography across the country. And so a quick thank you to all of you again who have enrolled, and to those who haven't, please consider it, because I think it can make just such a huge impact to the population, and also hopefully, as will be discussed, it can be pretty rewarding too. Next slide. Oh, next slide. There we go. Okay, so becoming enrolled, defining a marriage and family therapist. These are some of the definitions that are in statute, and so starting with marriage and family therapists, have to possess a master's or doctoral degree, which qualifies for licensure. Or I see that I see my video is lagging a little bit. I might actually try turning off my video and see if this helps. So hopefully this will be better. Okay, so the marriage and family therapist must possess a master's or doctoral degree, which qualifies for licensure or certification as an MFT pursuant to state law of the state in which the individual furnishes the services, and where they are furnishing those services. Also performed at least 2 years or 3,000 hours of postmaster degree clinical supervised experience in marriage and family therapy in an appropriate setting, such as hospital, skilled nursing facility, private practice, or clinic. And is licensed or certified as a marriage or family therapist by the state in which you perform services. Next slide. The definition also on the mental health counselors is really largely the same. It's very similar, at least, to the marriage and family therapist definition. I'm not going to go through this, but just know that you have it in the slides with you. I will also add the additional information that I mentioned earlier, that an addiction or drug counselor that satisfies all these requirements can also enroll as a mental health counselor, which we think can be especially important for the treatment of substance use disorders. Okay, next slide. All right, so just a little bit on becoming enrolled. You can enroll electronically. It's called the Provider Enrollment Chain and Ownership System, abbreviated PECOS, or the paper CMS 855I enrollment application. And the online system is scenario driven and asks questions to obtain the required information for your specific enrollment scenario. It's oftentimes considered a faster and easier process than paper, but paper does remain an option to you as well. So all the information that you'll need on how to enroll, additional frequently asked questions, are available in the link provided on this slide deck. So if you want to access that and look at some additional questions, that's definitely a good resource, and probably where I'd turn to first. Okay, next slide. Okay, so some additional updates. I had mentioned the physician fee schedule. It's this big rule that comes out every year, and it's can be thousands of pages to get through. So I wanted to highlight some specific changes that are definitely relevant for marriage and family therapists and mental health counselors in particular. So in the 2024 physician fee schedule, these changes start January 1st, 2024, so they're already in place. We made a number of changes to the different code sets to make it such that marriage and family therapists and mental health counselors could build these codes. And so that includes changes to behavioral health integration codes. So if you're practicing in conjunction with a primary care practice and you're providing integrated behavioral health care, you can build these behavioral health integration codes. And they're a type of care management codes that can be billed monthly depending on how much time is spent with the patient. We also made changes to the health behavior assessment and intervention codes to allow billing by marriage and family therapists and mental health counselors. So these services are used to identify the psychological, behavioral, emotional, cognitive, and social factors that are included in the treatment of physical health problems. So this is another way to integrate behavioral health into more of the physical health realm and integration into primary care as well. And marriage and family therapists and mental health counselors can bill for these now. And additionally, we took a broad look at the valuation of how much Medicare was paying for behavioral health services, including therapy. And we ended up increasing the valuation of these behavioral health services by 20% over 4 years. And so in the 2024 physician fee schedule, payment for services like therapy and also these health behavior assessment intervention codes went up by 5%, and they'll go up 5% every year for 4 years to about a 20% bump in payment for these services. We think that that can also be attractive to those clinicians who are considering enrolling and especially for therapists and counselors as well. Next slide. Okay, and so just recently, we also finalized the 2025 physician fee schedule. It just finalized on November 1st of this month. And there was a few areas to highlight in particular. There's a ton of changes here. The final rule is over 3,000 pages, but I wanted to highlight a few areas. The first is that we finalized coding and payment that can be billed by practitioners whose covered services are limited by statute for the diagnosis and treatment of mental illness, such as MFTs and MHCs. And in particular, that coding is there's new payments for safety planning for patients in crisis. And so what we've seen in the evidence over time is that a much more structured safety planning service, if it includes all the elements like assessing for possible risks that the individual might have at home, understanding social supports and how those come into play and can be protective, and developing plans of action, that more structured safety planning can be really important for preventing suicide and overdose. And so we finalized this payment for these codes that can be billed in 20-minute increments to actually conduct the work to conduct that safety plan with the patient. And MFTs and MHCs can bill for that. And then there's also follow-up codes where there's a number of calls that can be made to check on the patient after the initial safety planning intervention, which have also shown to be really impactful in terms of reducing risk of suicide and overdose. And there was a number, there was additional codes for new devices for more digital prescribed treatments for mental health diseases that are FDA approved. And there's also a series of changes for opioid treatment providers in paying for a more diverse array of services and also medication for opioid use disorder. So I think with that, I'm really happy to pass it on to my fellow speakers to give you more of an in-depth look on what some of this means from a practice level.
Thank you, Dr. Jacobs. It is my pleasure to join you today to share some of my experiences of providing marriage and family therapy services to Medicare beneficiaries. My interest in working with older adults predated, my interest in working with older adults and their families was the impetus for me to pursue my degree in marriage and family therapy. Although I was fortunate to find workarounds that allowed me to serve this population over the years, it's been gratifying to finally become a Medicare provider earlier this year. And I'm grateful for the opportunity to share some of my experiences with you today. So I think most of us know that the Medicare population is comprised of two groups. About 10% of it is people with disabilities, and the other 90% are people over the age of 65. I'm going to focus my comments on the 90%. So there are many ageist biases in our society that affect availability of healthcare for older adults. For example, only a small percentage of health and mental health professionals in the US choose to specialize working with older adults. 3% of psychiatrists are geriatric psychiatrists, which leaves about 1 for every 27,000 older adults. And 3% of licensed psychologists identify as geropsychologists. Over the years, I've heard a lot of excuses and reasons that students prefer not to work with older adults. And some of my mental health colleagues have also shared their ideas about why this population wouldn't be satisfying for them. And some of those misconceptions are up here on this slide. You know, if people are old, of course they would be depressed. They're all depressed. They would prefer medication to psychotherapy. They don't want to change. Maybe they're private and don't want to talk to strangers, don't believe in therapy. They're in nursing homes anyway. And a lot of people believe that older adults think family problems should stay in the family. Well, in reality, 14% of the older adult population has at least one mental health disorder. And in 2020, 33% of the Medicare population used at least one behavioral health service. The reality is that many of these things on this slide are true of people of all ages, and it's a mistake to regard older adults as a homogeneous population. Next. And next. Thank you. Okay. So let's take a closer look at the diversity that exists among the over 65 population. For example, there are 3 generational classifications embedded within this group. We have the greatest generation, born around the turn of the 1900s, the silent generation, born in 1928 and beyond. 8% of them are still comprising this population, and baby boomers, born from 1946 to 1964. They all have different relationships with mental health. Let's start with the silent generation, for example. This was the generation that was brought up. They were socialized to be seen and not heard. Many of them came from immigrant families who experienced oppression and discrimination, and they thought they were safer, not calling attention to themselves. The focus of this, having lived through world wars and the Great Depression, was on survival and sacrifice. They didn't really think about well-being. So mental health is a taboo subject for a lot of them, or they were socialized to be stoic, self-reliant, and not to seek help. And then there were the baby boomers, who were more the Vietnam generation, and they were the ones that really gave rise to personal growth and mental health through self-help. And there's a lot of variation in this group in terms of psychotherapy preferences versus medication preferences. But we do know that of all of the groups, this group has the highest rate of substance abuse than other previous generations. So if we look at some other variation on this slide, we see that there's a difference in terms of gender, in terms of who's married. The divorce rate is really pretty high. Actually, 36% of adults over the age of 50 are divorced, and the rate goes up with age. The divorce rate for those between 65 and 74 is almost 40%, and it's almost 25% for people over the age of 75. And in this phase of life, many people are repartnering or remarrying. A lot of people, almost a quarter, live by themselves. Some live in generational households, which add to different family dynamics as people move through the family life cycle. There are racial and ethnic minorities, and a lot of people are still working, almost 20% of people. And what's interesting also is that over 1 million of them are grandparents raising grandchildren. So we used to think about the family life cycle as something that was linear, where you found a partner, you had children, raised your children, launched your children, then you retired and you became empty nesters and died. But what we see is that a lot of these things are not linear. Sometimes when families remarry, they get into the situation where they're having to have adult children living with them, and they have to go through relaunching. And then there's also divorcing, repartnering, adjusting to new relationships. There are a lot of things that are happening in this population. Next. So the thing I want to call attention to in this slide is that when we look at families in later years lasts about 25 years. There used to be this conception that after you launched your family, you just waited to die. And now that people are living longer, and this is 25 years, we're really redefining what happens in this phase of life. Next. So between retirement and death lies a new phase of life, often called the third age. Next. So since many older adults spend so many years in this later phase of life, they choose to do a variety of different things. Many continue in the labor force, either by choice or necessity. Some are confronted with their own health issues or the health issues of others. Some take on caregiving responsibilities, either for parents, for spouses, or maybe for children. But this is also a time when older adults are coming to embrace this third age. So what is that? Well, the third age refers to that time in life when older adults are discovering that they've taken care of a lot of the have-tos in their lives, the family obligations, parenting, work responsibilities, and they're discovering that there's a little bit more time to think about how they want to spend their remaining years, how they want to continue growing, and really some time of reflection of whether or not their life is really the way they want it to be. Some people explore creative opportunities, or maybe their relationship to their own spirituality. And a lot of people are working to reconcile family and other interpersonal relationships. People are looking for meaning and purpose. Contrary to those societal misperceptions, adults over the age of 65 report the highest rates of happiness, contentment, and fun. Next. So let's take a look at what an MFT practice looks like with Medicare beneficiaries. Next. So here is a snapshot of the Medicare clients in my practice. And I think about, did clients choose me because I'm an MFT? The answer is some of them did. Some of them were grateful just to find somebody who took Medicare. But what you'll see as we go through some of the next slides is that there is a relational or a family component to treatment in most of the Medicare people I see. So about half of the people that I see are women, which is interesting because that means the other half are men, and we wouldn't have assumed based on those biases that older men would come to treatment. The mean age of the people I see is 79, with the range from 71 to 91. I find them to be very motivated. They're usually referred by themselves. A couple are referred by physicians for depression or anxiety, but most refer themselves because they're very motivated to work on something. And the show rates in this population are really excellent. Next. So here are some examples of what brought my clients into treatment. I think as we review these presenting issues, I think you'll see that many don't reflect the misconceptions I shared at the beginning of the presentation. So for example, the first one is a 65-year-old male, and he really wanted to talk about a way that he could work to be consistent with his authentic self. He realized he too often aims to please other people, and this is at the expense of his own happiness. The next one is a 71-year-old male who came in with symptoms of depression and anxiety. And he is somebody who's a caregiver of his wife with dementia. And he wanted to increase his sense of mastery over being a caregiver, also to reduce his negative feelings about himself, because he didn't believe he was doing all the things he needed to do and felt that he wasn't always as kind to her as he wanted to be, and he felt guilty. He also wanted to reduce his reliance on alcohol as his number one coping mechanism. The next one is a 74-year-old female, and she is somebody who lives in a different state than her son, who is 33, adopted, and always had an insecure attachment because of the adoption. He has a long history of mental illness and substance misuse and suicidal ideation, and he refuses to seek treatment. And after years of arguing with him about treatment, she decided she would come into treatment to try to see how she could better help him and how she could help herself cope with the anxiety and his anger outbursts and the feelings that she had that she's failed as a mother. Next. Next is a 71-year-old male, and his wife came in with their 28-year-old lesbian daughter. And the daughter had a recent episode of major depressive disorder. And they came in looking to improve communication and really reduce the number of anger outbursts they had in their family. Their daughter had a very isolating experience of being gay. And she really thinks that her parents are people of privilege who really had a life where they didn't have any of the adversity that she dealt with. And she was really, really struggling to try to get them to understand it. So we were working on really helping them share emotions and increase the family skills at reflective listening in a way to reduce the father's sense of anxiety that he was having about his daughter. Next is a 74-year-old female who has metastatic breast cancer, but she also is taking care of her 75-year-old husband who has a neurologic disorder. And she came in asking to figure out ways to prioritize her own health and to figure out how she could put herself first for once and be able to say stuff out loud and feel less guilty. And next is a 91-year-old female who had symptoms of anxiety and depression, wanting to find courage to open up to her children. She found when moving into a senior living community that this was something that came very easily to her friends, and she felt very envious that they had this ease that they could just talk about emotions and share feelings, and that she really couldn't. And she had so much regret that there were things that she wanted to share with them, and she wanted them to feel comfortable coming to her. She also said she wanted to come to terms with what it means to be 90 years old, because ever since she turned 90, she felt different and wanted to understand that process and process it. Next. So the last couple, an 89-year-old father this was an 89-year-old woman looking for validations of her feelings to want to remain independent and in her own home, despite the fact that her health is failing and she had heart failure and other kinds of issues. Her family was very, very close, and they always considered her the strong matriarch, and they would not give her any space to talk about death or end of life wishes because they couldn't bear it. But she wants to talk about it. She didn't want to burden them, so she chose to reach out to me. The next one I'm going to pass over, and the last one is a 78-year-old gentleman in search of an off-ramp for retirement. He's grappling to hold on to his professional identity and doesn't really understand and can't really wrap his head around what it would mean to give that up and what would be left of him. And of course, interspersed throughout all of these things are losses that people experience in terms of spouses, health, friends, function, those kinds of things. So for me, it is a privilege to be invited into these spaces where people who perceive themselves as matriarchs, patriarchs, and elders are allowing themselves to be vulnerable in order to promote their own mental health and well-being. Next. So I hope I've conveyed how meaningful working with Medicare beneficiaries can be. For any MFTs considering enrollment, I encourage you to check out the excellent resources available through the AAMFT website, or feel free to contact the staff there who are very available to help and provide guidance in this process. I found the application process wasn't overwhelming. The scariest thing is that the terms and the names of the forms are foreign, and it seems a little bit scarier than it is, but I found these resources to be very helpful. And now I will turn it over to Mary Jernigan.
Hello, everyone. Good afternoon. Thanks so much to Dr. Brudorsky and Dr. Jacobs for sharing this valuable information on best practices and credentialing as well for Medicare clients. It is an honor to be on this panel, and I've learned so much already for you. Well, my name is Mary Jernigan. Hi, everyone. Licensed clinical mental health counselor and national certified counselor, sharing perspectives both as the immediate past president of Licensed Clinical Counselors of North Carolina and practitioner in the Community Mental Health Agency of TRICARE Counseling and Consulting, being credentialed with Medicare since January 2024. And my clinical focus is on the lower income clinical research deserts of North Carolina. And I currently have approximately 20 Medicare clients, ranging from mid 20-year-old disability clients to seniors as high as in their 80s. And some of my newest clients have been waiting for years for treatment because they could not locate a clinician paneled with their Medicare insurance. And I just want to thank so much to the National Board of Certified Counselors for empowering and equipping counselors and other disciplines to serve this population. NBCC was so instrumental in unifying with other stakeholders at the federal advocacy level towards Medicare inclusion last year, and have continued to lead the way nationally, encouraging counselors to panel with Medicare. And also, I just want to make a quick note from North Carolina, take a moment on behalf of LCCNC to thank all of the practitioners from all over the nation who rallied around Western North Carolina Hurricane Helene recovery efforts. The North Carolina Board of Licensed Clinical Mental Health Counselors has opened up temporary emergency reciprocity so that counselors and practitioners from every state can provide support for those suffering the most. LCCNC has also partnered with stakeholders to develop a list of pro bono database of clinicians offering support, as well as a Clear Hurricane Helene webinar available for free at lccnc.org. So my heart of the message today is to highlight both the human advancements in expanding the clinical workforce for the Medicare population and credentialing with Medicare, and that it also advances the profession of clinical mental health counseling. Now, prior to this decades-long advocacy victory, counselors were forced to refer their patients out to social workers and psychologists at their 65th birthday or at the approval of disability. And this created ruptures of care for these clients who had to detach from their therapeutic alliance that they had held dear for so long. Next slide, please. So fast forward to the COVID pandemic era that created a momentum towards the shift of access to care barriers that we at LCCNC refer to as the golden age of counseling. And this was a phrase coined by our then advocacy chair, Stephen Allman, in 2023, in observance with the awe and wonder of legislative permissions and acknowledgement that we have fought for decades. When the Center of Disease Control and World Health Organization's public media acknowledgement of the prioritization of mental health paralleled alongside ICU pulmonology and the expedited pharmaceutical vaccine innovation, mental health had leveled up to the attention and destigmatization not seen yet on this global scale. And this ripple effect manifested in additional achievements such as unprecedented reimbursement for telehealth counseling, the national movement of the Interstate Counseling Compact, reduced prior authorizations, and the medical miracle of Medicaid expansion, a bipartisan legislative legislative milestone for North Carolina and the grand finale of Medicare inclusion. Next slide, please. So our stakeholders at the state legislators and national capital have passed the torches of the innovative potential of this golden age to the profession. And how will we respond? So in 2023 and 2024, LCCNC developed a Medicaid Access to Care report derived from data across partners and stakeholders, as well as raw survey data from our members. And the findings identified that major access to care barriers that prevent credentialing with managed care is the administrative burden of documentation and audits, as well as lower pay scale compared to other private or insurance pay. And additionally, in the years leading up to Medicare inclusion, our counselor advocates were frequently replied by state legislators that while allowing Medicare credentialing to counselors would be nice, that they believed it could financially overwhelm the system. And we know that the opposite is true. Clinical mental health counseling to Medicare populations is good preventative medicine that will reduce the cost of hospitalizations, reduce pharmaceutical costs, and strengthen local economies. And for those reasons, while we can advocate to increase pay rates and reduce that administrative burden, our greatest unity strength across the nation depends on more counselors initiating treatment of Medicare clients. Because when counselors integrate at the table with other specialties such as endocrinology, neurology, and oncology, the counseling profession and mental health are elevated. Treating Medicare patients with higher physician contacts empowers and challenges other disciplines to view their patients holistically from a body, mind, spirit perspective towards the holistic person-centered healing. We as clinical mental health counselors know from our history the restorative shift when Carl Rogers brought the medical miracle of person-centered approach for his patients into the room with the greatest minds in science. Let's advocate for the whole human in our clinical communities as well. Next slide. And speaking of physicians, there's increasing pressure on insurance demands to increase their caseloads, thus reducing the average length of the patient face-to-face time to approximately 10 to 15 minutes. Medicare inclusion affords counselors the opportunity to explore at the generous length of the FaceTime CPT code for 45 to 60-minute patient explorations. This time span helps us to explore lifestyle patterns, environmental vulnerabilities, and past traumas that could be contributing to those chronic mental health conditions, chronic medical conditions. These hours are hours of collected work that all that face time can then be surmised in clinical dictation to the patient's primary care, leading to more accurate diagnosing and treatment. The counselor's clinical insights gained for collaborative chart review are life-saving. Next slide. Life-saving counselor interventions. It's really powerful. So, what could happen in our communities and in our profession if each one of us on this webinar today took on at least one Medicare client on our caseload? Now, it is true that advancing the profession also includes higher self-pay rates that equate to other specialties. But also for those private practitioners who are here today advancing the profession in this way, I'm not asking you to completely shift your practice, just to join the movement for our communities and the profession and consider just adding one Medicare client to your caseload. Next slide. The power of the therapeutic alliance, the power of life-giving presence brings the seniors or chronically disabled out of isolation and empowers them to reconnect to their communities. Meeting seniors where they are balances neurohemisphere health through feelings identifications and relationships built on the areas of life that they are most willing to offer vulnerability. The modalities of dialectical behavioral therapy for pain management, mindfulness, expressive art therapies for the inner child work and enhancing neuroflexibility and creativity, and feelings identification can all be transformative health interventions. Counseling seniors and clients with disabilities can strengthen counselor basic fundamentals such as empathy, congruence, presence, and unconditional positive regard as you experience improved outcomes with some of the most rewarding and appreciative clients on the human scope. Next slide. Credentialing is simple and is managed the same way that clinicians would apply for an MPI number with the full support of the MACs. And with open enrollment now in effect, now is the perfect time to take the leap and credential. Next slide. All right. So with that, clinical mental health counselors, I wish you a happy first billable year of Medicare. It's worth celebrating. We made it. Let's make a difference in our communities together, one senior at a time. Thanks for having me today.
Thank you, Dr. Jacobs and Dr. Pogorski and Ms. Mary Jernigan. What wonderful information and what wonderful advocates for the professions of marriage and family therapy and for mental health counselors. We so appreciate you sharing your time and your knowledge and your expertise with us today and your enthusiasm. This update from CMS and the information on how counselors and MFTs are participating and providing crucial healthcare services to Medicare clients has been very helpful and very enlightening, and I'm excited. You've provided critical information to help us bring care to Medicare beneficiaries and to learn how we can improve those services in 2025 looking ahead. We appreciate the partnership and the connection with our practitioners. And now we're going to move on to a question and answer portion of our program. So people have been putting questions in the chat, and we are going to try to get to as many of those as possible. Let's see. I think the first one is going to be for Dr. Jacobs. And that question is, can you help me understand the physician fee schedule? Is there a resource or a place on the website that explains the different categories of the fee schedule?
Sure. And hopefully you can hear me and my video is working okay. So there is certainly a place, there's a few places that you can look that I'd recommend for more information. Nikki had put in the chat a link that is a Medicare Learning Network article that specifically goes over some of the behavioral health coverage. And a lot of that is especially relevant for marriage and family therapy and mental health counselors. And the other place that I would look is actually if you just Google the physician fee schedule, it'll bring you to a CMS landing page. There's also something there called the physician fee schedule lookup tool. And so if there's a specific code that you want to know more about, you can type that code in and it will tell you the reimbursement rate. And it will come out with like a relative value unit and the reimbursement rate for your area specifically. So those are maybe some areas to start. And every time there's a new physician fee schedule published, we come out with additional fact sheets and education materials as well. So you can find that for the 2025 physician fee schedule that we just came out with.
Very good. Thank you. Thank you so much for providing those resources. While I have you there, I'm going to ask you one more question about enrollment that has come in as well, if you will, because you mentioned that 56,000 mental health counselors and MFTs have enrolled so far, which is wonderful. But one person has written in wondering if there is a state-by-state breakdown on the data of the MFTs and the MHCs that are enrolled providers. Could you speak to that?
I think we are tracking that on the back end. I don't know exactly what shape that data is in, so I can't promise anything, but that's something we can look into more.
Okay, so maybe in the future that would be something that people would have available to them so they could see on a state-by-state basis. Okay, very good. Let's see here. One person has written in saying that they would like to learn the process for enrolling in another state, as they are currently paneled in the state of Massachusetts and would also like to enroll in another state. Dr. Jacobs, can you speak to that as well?
I would recommend, so the slides that I went through, there's a link there on frequently asked questions. It goes through some of the procedures for enrollment, and also includes how to get in touch with the Medicare administrative contractors. And so they help to oversee that process, depending on the geographic area and state that it's in. And so I would not only look through those FAQs, but also get in touch with the Medicare Administrative Contractor, or MAC, of the area in which you're looking to enroll. But that's a good question. Hopefully some of those FAQs will help.
Yes, I definitely have found the FAQs very helpful. So thank you for mentioning those again. I think people will find the answers to some of their questions there. I'm going to ask you one more question since I have you here, and your video is working really well right now as well. So thank you for that. As I was just saying earlier, and you stated in your slides, around 56,000 mental health counselors and MFTs have enrolled. And I'm just wondering myself, and I think the coalition is probably wondering too, if this number is in line with what CMS's expectations were for the newly added providers, if you feel like we're on track, or what your expectations were. And in addition to that, do you have any suggestions for initiatives that organizations like ours could take to encourage provider enrollment? And I think that Carol and Mary are wonderful advocates for that, and we're speaking from personal experience on that, but do you have other suggestions as well?
Yeah, I think that to start with your first question, the 56,000 number is a really robust number. It's actually beat expectations, I think, initially, and where we would be at this point. And so we are very pleased with the amount of enrollment. And I think at the same time, we also recognize that there's a lot of room to grow, and there's still a lot of applications in process, which we're also excited about. But we want as many MFTs and MHCs to enroll in Medicare as possible, because we know that every time another therapist or counselor enrolls, that's perhaps like an entire community of people that will have better access to behavioral health care. And we know the transformative effects that can have on their health. And so to get to your next question, I think that webinars like this are fantastic. And I think better than hearing from me is hearing from MFTs and MHCs, which is why I was really happy to listen to Dr. Podgorski and Ms. Jernigan, like, talk through some of the actual clinical implications in practice. And I think that can be really powerful in just the narrative of what it means for individual providers to enroll, and what it means for those individual patients as well. So I think you all are probably better positioned to figure out exactly how to do that, but I found this webinar very impactful for me. So hopefully more like this would certainly help too.
Yes, thank you for answering that. And I, definitely agree. That's why we wanted to have you to come in and provide some information, but also some people that are actually practicing in the field to share what their experiences are like, if people are wondering what that may be like. Which actually, I'm going to take you off the hot seat for a second and let one of our clinicians answer as well. One person has written in just wondering, is providing mental health services for Medicare clients, is it burdensome to the clinician? This person is saying that they're retired and they don't really have a lot of experience in this area. And I think this is a question that a lot of clinicians are having if they don't have experience in this area. Is it burdensome? Is it burdensome? Is it hard to get prepared to work with the Medicare population? And Mary and Carol, I might like just both of you speak to that if you would like to.
Go ahead, Mary.
You can go for it. Oh, okay. I would say that's a really great question. And from personal experience, it's actually the opposite of burdensome. I think that leaning into those person-centered clinical interventions, especially the power of presence, polyvagal tracking with the client, sometimes it can feel during the session because you're in that basic feelings identification stage, just encouraging, like Dr. Podgorski was mentioning earlier, from the 1920s generation, really kind of that stoicism. It can feel during the session like you're not, quite doing enough, need more, interventions. But however, at the end of the session, that polyvagal nerve theory, you feels like that you've done a lot of work from those basic person-centered empathy, congruence, and feelings identification. So trusting the process, trusting the wonderful healing power of that therapeutic alliance, trusting that can help support, but it's opposite. It's quite energizing.
And I would add that most of the evidence-based treatments that work in other populations work with older adult populations as well. I think the most important thing is just being curious and listening to people's story and having humility about what their experience is. And I think it's once that connection is made, it's not really different than doing therapy with people from any other age group, except I did read some articles recently that said that when older adults are working with younger therapists, they tend to want to take care of them. So you might have to expect zucchini bread or muffins or something, because there seems to be some sense that you're getting something, but they want to give something back. And I did notice that that was one thing in an article that was talking about how to prepare younger therapists to work with Medicare beneficiaries.
Wonderful. Really, really good, good points to make there. And, I think it's important to dispel some of the myths around working with this population and some of the anxieties that clinicians may have. And I do want to say as well, the coalition has been providing this Medicare series really, and some of them are geared towards enrollment and the administrative side of working in Medicare, but also we have quite a few clinical webinars that we have provided as well, and we will keep doing that through 2025. So if you are interested in clinical aspects of working with this population, we are offering those as well. So stay tuned for those in 2025. We already have some really wonderful plans and webinars planned for substance abuse in older adults, and also suicide, grief, some topics such as that we will be focusing on. So thank you for that. While I have you two, I'm going to ask you one more question too. A person has written in, let's see here. How might MFTs and mental health counselors practice with Medicare clients across different settings? And they put the example of integrated care, private practice and outpatient clinics, certified clinics, hospital-based, and those kinds, skilled nursing, those kinds of populations. Can either of you speak to that?
I have worked in a skilled nursing facility, and I did it through the auspices of a training program because it was before we had the opportunity to bill Medicare. But there are possibilities for people to provide therapy in nursing homes. I also provide therapy through a dementia clinic. That's not the population I talked about today, but I also do family therapy in our memory care program at the university. So there are opportunities for people to be embedded in different. I have a lot of colleagues who are in primary care settings and in geriatric practices. So those possibilities exist. That is one other skill set I wanted to touch on, is just that when people, you don't need to feel alone in working with older adults. And I think the ability to collaborate with primary care and other specialists and family members is a really important thing, or geriatric care managers. I think all of learning that skill is really an important one, especially in managing people toward the end of life.
Yes, I would definitely agree with that. One thing I'm noticing with Medicare patients, with working with seniors, is they really enjoy the in-office sessions. And so sometimes if you're, and I think I saw another question talk about kind of like the balance perspective. So if you're a practitioner that's across all disciplines that really kind of enjoys the telehealth, one way to kind of serve Medicare population is going into the communities assisted living facilities where there's 100% show rate, because you're going from room to room there. So it's a great way to help and serve this population. But I do agree with what Dr. Percy said earlier. The show rate is excellent for those in-person sessions as well.
Wonderful. Thank you for answering that, Mary. I was going to ask a question about telehealth, and we are running out of time, unfortunately, so I'm glad you encompassed that in your answer to your question. Doug Jacobs, I'm going to ask you one more question. I think we're going to have to end up with because we're running out of time. And I think this is a very good one to end with. A person has written in and wanted to know if there is an application fee to become a Medicare provider. And I can say on behalf of MBCC, I have had people write in and ask me that. So can you speak to if there is a fee to become a Medicare provider?
Not that I'm aware of. So we really want folks to sign up, and so any barriers to that, we're trying to be pretty thoughtful of. And so if the zucchini bread doesn't do it for you, maybe the lack of fee will.
Exactly. Something speaks to everyone, right? And you are correct. There is no fee, and we don't want people to have that misconception. To become a Medicare provider, there is not a fee, and zucchini bread awaits you as well. So with that, I'm going to unfortunately have to stop the Q&A period and wrap up here. The Medicare Mental Health Workforce Coalition and NBCC would like to thank Dr. Jacobs, Dr. Pogorski, and Ms. Mary Jernigan for sharing your time and expertise with us today, and everyone for attending this webinar. We have also provided a few slides with Medicare resources, including how to enroll in the Medicare program. The link to the session evaluation is posted in the chat, and we will also email it to you in case you have missed it following the meeting. To receive continuing education credit, you must complete the evaluation, including the attendance attestation, by November 28th at 5 p.m. Eastern Time, and certificates will be emailed by December 5th. We will only be providing credit for live attendance of this webinar. We hope that you found this session informative, and we look forward to seeing you again in early 2025 as we continue our Medicare webinar series. Thank you, and have a wonderful rest of your day, and enroll in Medicare. Thank you.